Okay, everybody, we will go ahead and get started. Good morning and welcome to the Vaccinations webinar. This webinar was done with collaboration from Networks 10 and 12 along with Telegen Quinn QIO. My name is Mandy Vyers and I'm a Quality Improvement Advisor with Networks 10 and 12. Next slide, please. I just wanted to go over a few housekeeping items before we get started. We will hold all questions and comments until the end of the presentation, where we will hold a Q&A session. You can ask your questions a couple ways. One way is to use the raise hand feature, and we will unmute your line so that you may ask your question. And then the other way is to use the questions box. So not the chat box, but the questions box. And you can type those questions in at any time during the presentation. We'll get to those at the end of the presentation. Next slide, please. Here are some objectives for today's presentation. We will recognize the higher risk of infection complications among the ESRD patients, learn the current vaccination recommendations against COVID-19, influenza, and pneumococcal infections. And then lastly, understand the safety monitoring and benefits of these vaccines, including lower hospitalization rates. Next slide. I know that some of you are familiar with the ESRD networks, but for those of you who may not be as familiar, the ESRD networks were created out of the Social Security Act that provided Medicare coverage to individuals with end-stage renal disease with the initial purpose of improving cost effectiveness, ensuring quality of care, encouraging kidney transplantation and home dialysis, and assisting patients to return to work. CMS relies on the network organizations to develop a relationship with the dialysis professionals, providers, and patients and create a collaborative environment to improve patient care. Next slide, please. This here is a graphic representation of all the current 18 ESRD networks. And then you can see our networks are highlighted there. For Network 10, we cover the state of Illinois. For Network 12, that includes the states of Missouri, Kansas, Nebraska, and Iowa. And now I'm going to pass it over to Lynn Bergero from Telegen, who will talk a little bit more about who Telegen is and what work that they do. Lynn?
Thank you, Mandy. I will give just a brief overview of Telegen and Telegen Quinn QIO. Telegen is a population health solutions company. We partner with U.S. government agencies and also with state Medicaid agencies and health plans to improve health outcomes. Within Telegen, as a quality innovation network, quality improvement organization, we serve the states of Illinois, Iowa, Oklahoma, and Colorado. And we bring Medicare beneficiaries, providers, and communities together in data-driven initiatives that increase patient safety, that make communities healthier, better coordinate post-hospital care, and improve clinical quality. We also provide technical assistance and convene learning and action networks at no cost to support healthcare QI at the community level. Our offerings include QI, which includes comprehensive COVID-19 support, also customized technical assistance in various areas such as human-centered design, community organizing, motivational interviewing, patient and family engagement, and team steps. We provide actionable data analytics support and support national benchmarking as well. Our most important function really is to provide a network to share and spread our partners' tools and best practices and outcomes. And we also develop learning collaboratives using the Institute of Healthcare Improvement's IHI Breakthrough Series collaborative model. The graphic you're seeing nicely displays the scope and depth of the work that we do. We work with our partners to improve nursing home quality, to increase the quality of care transitions and chronic disease self-management, to increase patient safety, and also to improve behavioral health outcomes, and most importantly, decreasing opioid use and adverse drug events, which is an intensive focus of our work over the next several months. Permeating all of these initiatives is our commitment to support local communities, support vulnerable populations, and reduce healthcare disparities to build equity into everything we do, and to increase patient and family engagement. So to learn more and to join us in partnership, feel free to visit our Telligen QuenQIO webpage, or feel free to reach out to me directly. My email is on the final slide. And now it's my pleasure and privilege to introduce our distinguished speaker for the day, Dr. Marie Philip Neary. Dr. Philip Neary is a professor of medicine at St. Louis University School of Medicine. After earning a medical degree from the University of Guyana, she completed residency in internal medicine at University of Missouri, Kansas City, and fellowship in nephrology at St. Louis University. She joined the Division of Nephrology at St. Louis University and also obtained a Master of Public Health and Doctor of Philosophy in Health Management and Policy from St. Louis University. Dr. Philip Neary is board certified in nephrology and internal medicine and a specialist in clinical hypertension. Her leadership roles include Medical Director of Outpatient Dialysis at SLU since 2006 and Continuing Medical Education Accrediting Director. Dr. Philip Neary is an active member on SLU's Biomedical Institutional Review Board. She is the current Vice Chair on the Missouri Kidney Program Advisory Council and collaborates with the National Kidney Foundation. She is also a member of the Nephrologists Transforming Dialysis Safety Project Committee, which is a national partnership between the American Society of Nephrology and the CDC. Dr. Philip Neary treats patients with a broad range of kidney disorders and hypertension. She provides evaluation and management of acute and chronic kidney disorders and resistant hypertension. Dr. Philip Neary has participated in several clinical trials. Her research interests include chronic kidney disease, hypertension, dialysis, and health outcomes. Please welcome Dr. Marie Philip Neary.
Thank you, Lynn. As a nephrologist, I would like to welcome you today to this very important yet a challenging topic in dialysis patients. I may not be able to cover all the topics today, but I'll be happy to reach out to my infectious disease colleagues for any difficult questions that I may not have answers today. So to start with, chronic kidney disease is a condition where infections are very common, and hospitalizations and mortality in end-stage kidney disease patients are second only to cardiovascular disease. Dialysis patients have higher annual mortality rates due to sepsis compared to overall general population. Yet, there is a barrier to infection control due to reduced immune response to most vaccines in dialysis patients compared to the general population. Next slide, please. This chart demonstrates monthly mortality among dialysis patients in the United States between January 2016 and August 2020. As you can see, there are 4 or 5 years shown here, and there are peaks during the colder months prior to COVID pandemic, which likely represents the flu pandemic, the flu season, and increased prevalence of pneumococcal infections. And in 2020, you can see a higher peak throughout the year, in fact, and including the summer months, which fits in with the COVID pandemic. So it is only appropriate to talk about these 3 infections today. And also I wish to point out there are other vaccinations that are relevant for dialysis patients, and we will not be covering today. Next slide, please. Chronic kidney disease patients have increased risk of infections due to a number of reasons, due to older age, multiple comorbidities, including diabetes, hypertension, COPD. They often have immunocompromised states. Many of them come from a nursing home and have contact during transportation with many other patients. At the dialysis center, there are a high number of personnel and patient contacts that also predispose them to infections. They have lower response to vaccines for a various reasons as well. They have lower number of B cells and T cells, reduced T cell response to antigenic stimuli, impaired monocyte functioning and inadequate antigen presentation, and impaired function of neutrophils. What it all means is that their white cell function is not as robust as in someone without kidney disease. Next slide, please. So let's turn our focus to COVID-19 pandemic, which is currently the very important topic. Next slide, please. So this data was obtained on February 7th, and as you can see, this is indeed a pandemic involving all over the world, and it is, as shown in the darker shade, United States is one of the countries that are leading the pandemic numbers. Next slide, please. So worldwide, there have been over 400 million cases of COVID reported and over 5 million deaths. And the good news, though, that although we have had high number of cases throughout the pandemic, the death rates have remained stable even through the Omicron surge over the past few months. And one of the biggest help that we have had is the vaccination over the past year. And as you can see in this chart, there are left and right axes. The left axis represents 7-day moving average of number of cases, and the right axis, the hospital admission and death rates. So the deaths have been, represented by the bottom curve, has maintained fairly stable despite increase in the number of hospitalizations through Delta variants, as shown in the darker shade, and then in the latter period due to the Omicron surge. Next slide, please. COVID-19 is a multi-system disease. Numerous short and long-term complications involving almost all organ systems have been reported in these patients. Data from a prospective multi-center cohort study involving 302 healthcare facilities suggested nearly 50% of the patients admitted with COVID-19 have had at least one in-hospital complication. So obviously, COVID-19 affects the lungs in majority of the patients, but the other complications that are relevant in these patients have been mostly reported for these systems, including renal system, respiratory with other complications, cardiovascular, neurological, and gastrointestinal system. Next slide, please. So this is a short list of the complications at different systems. Just to name a few, for kidneys, there's acute kidney injury, glomerulonephritis, and thrombotic complications involving multiple systems. Respiratory barotrauma and pulmonary aspergillosis have been reported. Cardiac, myocardial injury, arrhythmias, heart failure, neurological strokes, again due to thrombotic complications, hematologic, venous and arterial thromboembolism and thrombocytopenia, GI hemorrhage, ischemia, multiple neurological and musculoskeletal impairments, DKA in diabetics and even in non-diabetics, numerous dermatological manifestations, and in rheumatology, vasculitis and reactive arthritis. Unfortunately, I have lived through to see most of these complications over the past 2 years, and these are real and common in patients who are critically ill and hospitalized. Next slide, please. So what about COVID-19 infection risk in dialysis patients? They are at high risk for serious illness and death related to COVID. So far, the reported statistics include nearly up to 50% hospitalization rate and nearly 20 to 30% mortality rate, which is much higher compared to general population. Thankfully, though, dialysis units across the country have taken steps to mitigate these infection and complications thus far and have prevented much of these complications, both hospitalizations and death, compared to otherwise if we they had not taken these steps, the numbers would have been much higher. Next slide, please. So to date, we have numerous vaccines available in the United States. There are two main types of vaccines. One, mRNA vaccines. There are two types of mRNA made by Pfizer and Moderna, and a vector vaccine made by Johnson & Johnson. Another prominent vaccine made in other countries is a protein subunit vaccine. I will briefly mention that. There are also other less common vaccines that are prevalent in other countries. They might be relevant when we, occasionally we get patients from other countries and they may have gotten different kinds of vaccines, and it's good to know what is available globally. Next slide. So to talk a bit about messenger RNA vaccine or mRNA vaccines. So this technique is not new. It's been around for over a decade. Investigators have looked into this technique for many years in terms of vaccine as well as medications that have utilized this technique. Nevertheless, this is the first vaccine that we have been successfully able to administer using this technique. So what it really means is that messenger RNA vaccine basically sends a message to our cells to make more protein against the spike protein that's basically the infectious unit of this virus. So the messenger RNA takes a copy of this spike protein and allows the body to make the antibodies towards this spike protein, so that when someone is faced with an infection, these antibodies can counter these viruses and prevent us from getting serious illnesses. Next slide. So let's give it a try to see if we can learn a bit more about these vaccines through a short video. I do not believe the sound is coming through. We can stop and move forward. Sorry about that. So in contrast, the second common vaccine available in the United States is using a different technique called virus vector vaccine. Instead of the messenger RNA, this message is transferred to the body using an unrelated, harmless or inactivated vector virus, commonly used as the adenovirus. And the vaccine contains this inactivated virus with this message again, so that the body can make the antibody again to fight the infection. So similar technique, but through a different mechanism. Next slide, please. So this summarizes the three vaccine types we talked about: the mRNA vaccine, the viral vector packaging vaccine, the third vaccine, and then in between is the recombinant surface protein vaccine. So in all three types, you have a viral protein that's administered or sent to the body that gives the recipe or the message for the body to make the antibodies so that we can fight these infections. Next slide. So how do we develop these vaccines? This is indeed a long process and involves multiple steps. At the beginning, though, there's a long exploratory or preclinical stage. Fortunately, with the COVID-19 mRNA vaccines, this has been done for us over the past decade or so. The scientists have developed and refined this technique, and we had the technique available to start with. Then we go through several phases of clinical trials Phase 1 involves small number of individuals who are healthy, just to demonstrate a proof of concept. Then we move on to phase 2, involving a bit more in number of individuals to study the safety and efficacy of these vaccines. Then finally, we involve a large number of patients in phase 3 to further demonstrate the efficacy and safety of these vaccines. And typically, this can take many years. But because for a number of reasons in COVID-19 was very prevalent, so we had many patients who were able to participate in the trials. Second, there was a lot of investment to make this move forward quicker. And then the scientists also were able to do some of these phases in parallel rather than in series, so that they can minimize the overall time taken to move from phase 1 to phase 3. And finally, it goes through extensive FDA review and licensure before it can be marketed and used at a larger scale. With the COVID mRNA vaccine, there was emergency use authorization due to the nature of the pandemic. And there are ongoing safety measures, which I will come to even after the vaccines have been authorized and being used among the public at large. Next slide, please. Next slide. So let's look at the dosing recommendations for the 3 vaccines available in the United States. The mRNA or vaccines, Pfizer and Moderna, require 2 vaccinations. Pfizer 3 weeks apart between first and second dose, and then Moderna 4 weeks apart between the first and second dose, whereas Janssen's J&J vaccine only has 1 vaccine. All 3 vaccinations recommend a booster dose. For the mRNA vaccine, 5 months after the second dose, and for the J&J vaccine, 2 months after the second dose. In patients who are immunocompromised, an additional or third mRNA dosing is recommended 28 days after the second dose. For patients who have had Janssen's J&J vaccine, the booster could be either J&J or preferably an mRNA vaccine. Next slide. COVID-19 vaccine is thought to have many benefits. First of all, it prevents us from getting COVID-19 or becoming seriously ill or dying due to COVID-19. It lessens the risk of spreading the virus that causes COVID-19 to others. Adds to the number of people in the community who are protected from getting COVID-19, contributing to so-called herd immunity and making it harder for the disease to spread within communities. Finally, it prevents the virus from causing COVID-19 from spreading and replicating, which allows it to mutate and possibly become more resistant to vaccines. Next slide. Let's focus on reducing COVID-19 hospitalizations in the next few slides. So it's been shown that COVID-19 is effective in preventing hospitalization. And here I have selected 2 studies to show that. In the top panel, a study involving 13 states that are listed below between February and April 2021 showed the 2 age groups that are listed between 65 and 74 and 75 and older. In both age groups, the mRNA vaccines have very high efficacy rates in reducing hospitalizations, between 96 for both vaccines between the ages of 65 and 74, and over 90% effectiveness for patients over the age of 75. J&J was still effective, but a little bit less than the mRNA vaccines in the 85 range. The second study, involving 5 veteran hospitals between February and August 2021, they looked at different age groups. In the adult groups between the ages of 18 and 64, the effectiveness was comparable to the previous study, 95%, a bit lower in the older age group over the age of 65 years, about 80%, with an overall average of 87%. Next slide. This is going back to the 13-state study. There are two axes. The left axis shows the COVID cases, and the right axis, percentage of persons who are fully vaccinated. So the dark blue bars represent unvaccinated individuals, and I think this should be reversed. So the columns depicts the vaccinations rates, and I'm sorry, I take it back. The number of cases of COVID are represented by the columns, and the darker ones are among the unvaccinated individuals, and the lighter ones on the top are the fully vaccinated individuals. So as you can see, the cases are coming down between February and April as the vaccination rates increase throughout the time period. The mRNA vaccines were the common vaccine administered in the United States, and there were few J&J vaccines throughout this time period. Next slide, please. A similar trend was seen for individuals over the age of 75 years in this cohort. As vaccination rate improved, the COVID cases decreased over time. And next slide. So this is to demonstrate the effectiveness of mRNA compared to J&J vaccine in the top panel, and the full vaccination versus partial vaccination in the bottom panel for the individuals over the age of 65 years between February and April 2021. So the top panel represents the individuals who are fully vaccinated. The top two lines, Pfizer, followed by Moderna, and Janssen's J&J. As you can see, the Moderna vaccinations had better protection compared to J&J vaccination, as we previously saw. And the bottom panel shows individuals with partial vaccination. There was some difference between the age groups in terms of Pfizer vaccination. Patients who were partially vaccinated over the age of 75 years particularly had low effectiveness compared to those who were younger, with similar trend with Moderna, but not as distinct as in older individuals. Next slide, please. So this chart compares incident laboratory confirmed COVID-19 associated hospitalizations with different time periods. This was obtained in California data between May and November 2021. You can see some time periods where earlier on the individuals are getting vaccinated, and then around August, there was recommendation for additional primary dosing, followed by booster dosing in different age groups. And as you can see, the case numbers were still high, but declined with different actions throughout the time period, as shown in this graph. Next slide. This is another study showing comparing individuals who are vaccinated with the ones that are not vaccinated, and again the rates were significantly different. The cases, the hospitalization rates were significantly lower in vaccinated individuals compared to those unvaccinated. And as you can see, the two peaks, initially with the Delta variant, followed by Omicron variant, and thankfully the rates are starting to come down across the nation. Next slide. So let's look at COVID-19 associated hospitalization rate among different age groups. Overall, they were significant 16 times higher among unvaccinated adults 18 years and older compared to those who were unvaccinated. You can see some differences among different age groups, less significant or different among adolescents, followed by younger adults. But the high rates were still maintained for individuals over the age of 50 and over the age of 65 years, as high as 17 times compared to those unvaccinated. Next slide. These graphs were obtained from a landmark study that was published in New England Journal, and looking at different case incidents, hospitalizations, and death rates. You can see weekly incidents, and the blue line represents the individuals who are fully vaccinated, and the black line who are not fully vaccinated. And the case trends was varying quite a bit in those who are unvaccinated or not fully vaccinated compared to those who are fully vaccinated, who seem to have been well protected compared to those who are not fully vaccinated. Next slide. So this is a case control study involving 4,500 hospitalized adults from 18 United States, comparing fully vaccinated individuals and those who were not fully vaccinated. Again, showed lower hospitalization rate in this cohort. They were 85% lower hospitalization rate compared to those who were not vaccinated. And the risk of death and requirement for invasive mechanical ventilation was 67% lower compared to those who were fully vaccinated. Next slide. So this study looks at hospital discharge rates, the likelihood of being discharged, hopefully alive or leaving out of the hospital in adults who are hospitalized with COVID infections. Just want to point out a few differences. The top panel compares those who are immunocompromised and not immunocompromised. So the difference was less so in immunocompromised individuals, which we might expect because they're already at high risk, and the benefit from COVID-19 vaccination was probably not as robust as in those who were not immunocompromised. The bottom panel looked at adults between the ages of 18 and 64 and those who were 65 or older. Again, the difference was more wider in older adults and more protective for those individuals in terms of hospitalization success. Next slide. So this cartoon represents COVID-19 associated hospitalization rates after the addition of a third dose or booster dose in adults. Compared to the original series, once you receive the booster or the third dose, the difference in hospitalization rate was much higher. Overall, over the age of 18, the difference was 44-fold higher. And again, you see a bit of a difference in different age groups, the highest being among those who are 65 years and older. Next slide. This represents the COVID-19 vaccination rates across the United States. I just want to point out our states in the middle where we have a lot more work to do in our population. Next slide. So infection and vaccine immunity, both are protective for at least 6 months. COVID-19 vaccination is still recommended in patients who have had previous infections, and they seem to enhance the antibody protection and immune status. However, nearly half of previously infected adults in the United States are yet to be vaccinated. Next slide. So in terms of vaccine safety, as I mentioned, in addition to initial extensive approval process, CDC has invested in immunization safety through various ways. There's an immunization safety office that conducts 4 primary vaccine safety activities through these programs that's listed here. Vaccine Adverse Event Reporting System, Vaccine Safety Data Link, Clinical Immunization Safety Assessment Project, Emergency Preparedness, and Vaccine Safety. This information is readily available and you can visit to obtain more data. Next slide. Again, I want to emphasize that COVID-19 is an evolving, ever-changing pandemic, and data is being updated, and it is good to be current through visiting either FDA or CDC and other websites that are reliable sources of information. Next slide. So let's change focus to influenza vaccine. Next slide. So influenza has high burden among United States. This chart shows the incidence or prevalence between 2010 and 2011 through 2019 to 2020. Overall, it causes over 9 to 40 million cases of illnesses, 140 to 700 hospitalizations, and 12,000 to 52,000 death rates. So why do we have such a huge variation? As you can see in this top panel on the right, the rates have varied across the ages. The reason being, there are a number of characteristics of the viruses that can determine timing of the season, how well the vaccine is working to protect against these illnesses, and how many people get vaccinated. Next slide. So here, the 2 panels represent influenza-like illness in the ESRD population. Again, you have peaks through the colder months, which corresponds to high death rates during those periods. And overall, with 1% increase in quarterly influenza-like illness has been associated with 1.5 to 2% increase in relative mortality. Next slide. So one wonders, is it all the influenza and pneumococcal infections that account for seasonal variation in mortality? There was one study involving 15,000 individuals from 51 Renal Research Institute clinics demonstrated that there were also additional laboratory and physiologic variations, which makes you wonder if it is those that are leading to infections, or rather infections explaining those differences. Nevertheless, these seasonal variations are pretty striking. Next slide. So according to CDC data, estimated influenza disease burden affected by vaccination between 2019 and 2020 is rather significant. As you can see, it prevented 7.5 million flu illnesses, nearly 100,000 flu hospitalizations, and nearly 6,000 flu deaths, as shown here. Next slide. So you may wonder, we are required or recommended to receive annual flu vaccinations, and wonder what goes behind the scenes. So this is just to illustrate that CDC goes through year-long processes to determine the best combination of the viruses that are targeted through these vaccinations, and the safety monitoring that goes throughout the period, as shown in this cartoon. Next slide. So influenza vaccine for the current season, 2021-2022, is as follows. The FDA's Vaccines and Related Biologic Products Advisory Committee, after going through the steps that I mentioned earlier, met in March 2021 to decide on the components of the vaccine. So for this season, all flu seasons will be quadrivalent, meaning they are designed to protect against 4 different flu viruses, as shown here, 2 influenza A and 2 influenza B vaccinations. Most flu shots and nasal spray vaccines are manufactured using egg-based technology. However, an egg-free or cell-based quadrivalent vaccine is also available. Next slide. So there are 2 injectable flu shots in the US, inactivated influenza vaccine and recombinant influenza vaccine. There's also a nasal spray, the live attenuated influenza vaccine. CDC recommends annual flu vaccination for everyone 6 months and older, with few exceptions. It is important to remember that only the injectable flu vaccine is recommended for patients with kidney disease, along with many other conditions. The recombinant flu vaccine is approved for 18 years and older, and a high-dose version of inactivated vaccine is approved for ages over the age of 65. In general, September and October are generally good times to be vaccinated against flu. Next slide. So this is comparing mortality for those who have received both influenza and pneumococcal vaccination. So the take-home point here is that both vaccines have additive benefits. So for instance, the black line represents the proportion of patients who are surviving without either of the vaccines, and then red and green with one of the vaccines, and then the blue line above represents those who have received both vaccination with higher chance of surviving. Next slide. So one important concept to understand why the CDC has to revise the vaccination every year is because the flu viruses are constantly changing. They can change in 2 different ways, known as antigenic drift or shift. In the interest of time, I'm going to say that type A viruses undergo both antigenic drift and shift and are the only flu viruses known to cause pandemics, while type B change only by a more gradual process known as antigenic drift. Next slide. So as I mentioned, they do go through flu surveillance and revisions of the vaccinations on an annual basis. In the past, though, this had involved taking patients and growing in cultures to create the virus isolate that can then be sequenced. And with technology, we have been able to advance these methods and shorten the time that it takes to arrive at the best vaccines possible. And this has also enhanced other vaccinations such as COVID vaccine during this pandemic. Next slide. And last, we'll turn the attention to pneumonia vaccination. Next slide. So strep pneumonia is an endemic global pathogen that causes a wide range of clinical diseases, both in children and adults. Non-invasive pneumococcal disease includes otitis or ear infection, sinusitis, and community-acquired pneumonia. Pneumococcal pneumonia results in up to 400,000 hospitalizations annually in the US, and mortality rates between 5 to 10%, 7%. Pneumococcus is the most common cause of community-acquired pneumonia in adults. Nearly a fourth of them have been documented. Next slide. On the other hand, invasive pneumococcal diseases include bacteremia, empyema, meningitis, endocarditis, and osteomyelitis, which are more serious conditions compared to non-invasive diseases. And majority of these cases start with the streptococcal pneumonia as the primary focus. And they carry significant mortality risk, up to 10% for meningitis, 15% for bacteremia, and survivors can also be left with long-term complications such as hearing loss, seizures, blindness, and paralysis. Next slide. People with chronic kidney disease are at high risk for pneumococcal disease and prone to complications. Overall, the mortality rate for pneumonia is 14 to 16-fold higher in patients on dialysis than the general population. In a ESRD study that included an incident dialysis cohort of nearly 300,000 patients, 1 in 5 developed pneumonia within 1 year of starting dialysis, and nearly 40% of these individuals required hospitalization. Next slide. So what are the risk factors for pneumonia? In a study involving 15,000 patients with chronic kidney disease and 62,000 individuals without chronic kidney disease, chronic kidney disease came out as the top risk factor for developing pneumonia. Other comorbidities such as diabetes, asthma, COPD were also important risk factors. Next slide. So why do patients on dialysis are high risk for pulmonary infections? A number of factors can explain this. They have transient hypoxemia during hemodialysis procedure, exposure to other individuals and healthcare personnel, transportation to and from dialysis, their weakened immune system, and other comorbidities as mentioned. Next slide. Pneumonia infection is also associated with high rate of hospitalization, as shown here, with and without pneumococcal pneumonia. Those with pneumonia had high incidence of hospitalization compared to those without. Next slide. So until recently, 2 pneumococcal vaccines were recommended, as you may recall. Conjugated vaccine known as PCV13 or Prevnar 13 and PPSV23, which is a polysaccharide vaccine. So there are some differences. The Prevnar 13 covers 13 serotypes and uses modified non-toxic mutant of the diphtheria toxin as a carrier protein. So one advantage is that this vaccine also stimulates T-cell dependent longer-term response, which is efficacious against non-bacteremic pneumonia. On the other hand, the polysaccharide vaccine, which targets 23 serotypes, stimulate the T-cell independent and relatively transient antibody response due to lack of immunologic memory. Hence the reason to administer both in combination in the past, because they have different benefits of administering both in combination. Next slide. So just a little difference between the two vaccines. The diagram on the left, A represents the pneumococcal bacteria, and the B panel represents the 2 different kinds of vaccines. The one on the top, the polysaccharide, as I mentioned, does not result in long-term memory. It's just short-term response making antibodies. On the other hand, the one below has a carrier protein attached that allows triggering of additional lymphocytes that result in long-term memory. Next slide. So this is comparing the PCV13 in terms of primary and secondary efficacy endpoints. They were effective in reducing community-acquired pneumonia, non-bacteremia, non-invasive pneumonia, as well as invasive pulmonary disease. Next slide. So prior to PCV13, there was a shorter version, PCV7, basically targeting 7 serotypes, which was still very effective in multiple studies compared to those who did not receive this vaccine. Next slide. Next slide. This one looks at similar data involving PCV13, and once again, you have a robust benefit throughout in multiple studies compared to those who are unvaccinated. Next slide. So this gives a timeline of different vaccines. initially, the PCV13 was introduced in children, followed by adults. And then more recently, the PCV13 vaccination has been somewhat relaxed to state that there should be shared clinical decision-making for adults over the age of 65 or those who are immunocompromised. Next slide. So the updated CDC pneumococcal vaccine guide, which is great news for all of us, because there is a 20-valent pneumococcal conjugate vaccine that's been recently approved for use over the age of 18 years. It was approved in June 2021. There's another vaccine that's also a conjugate vaccine that targets 15 serotypes. So both are available now. Next slide. So as you can see here, the polysaccharide vaccine on the bottom targets 23 serotypes. The former PCV13 targeted 13 serotypes, but missed very many other serotypes. Therefore, the need to administer 13 in combination with 23. Whereas the newer version, the PCV20, targets 7 additional serotypes in addition to the previous form 13 conjugate vaccine. Hence, there's the current recommendation is no need to combine with the polysaccharide 23 vaccine. Next slide. So this is to demonstrate how this study was performed. This is a non-inferiority study. Next slide. And in terms of immunogenicity, comparing PCV20 to PCV13 in adults, they were very comparable between the two. Next slide. This is looking at individual serotypes, that the 7 additional ones that are covered by PCV20 compared to PCV13, and for each serotype, the immunogenicity response was pretty robust and comparable to PCV13. Next slide. This is looking at both local reactions shown on the left and systemic events within 7 days of vaccination. Again, there were no significant differences between the two groups. Next slide. So what are the current recommendations for patients over the age of 18 and with chronic kidney disease? If patients have never received pneumococcal vaccine, then they can receive only the PCV20 or the PCV15 with the polysaccharide vaccine 23 after 1 year. For those who have previously received the polysaccharide vaccine, then administer PCV15 or PCV20 1 year after the most recent PPSV vaccine. And then lastly, for those who have received either PCV13 or PPSV23, then continue the PPSV23 as previously recommended. Next slide. So how about using both pneumococcal and influenza vaccine? I previously showed that there is additive benefit, and multiple other studies have also shown that combining influenza and pneumococcal vaccine provides additional benefit, and they are both recommended for our patients, and both can be given at the same time. Next slide. So to end this talk, as I mentioned, vaccination is a quite challenging and ever-changing topic, and there's a lot for us to learn, and it's a difficult conversation with our patients. And I recommend embracing an attitude of empathy when discussing vaccination with the patients, even with those who are resistant and have lots of questions. So ask if they have questions, so if they're open to discussion about vaccinations, respond to their questions about vaccines and other topics, and finally respect individual opinions and decisions. And thank you for joining this webinar, and I'm happy to take any questions.
Okay, so we can now open up for questions. So once again, if you have a question, if you could enter into the question box, or you can use the raise hand feature and we will unmute your line so you can ask your question. So we'll give a few minutes here to see if anyone has questions. And Debbie, you can move to the next slide. The last slide, sorry. If nobody has any questions, this is our contact information. We want to thank everybody again for joining. There will be a survey that follows this webinar, so please, we would appreciate it if you could complete that and give us some feedback. And then also I wanted to mention that we will be sharing both the recording and slides out for anybody who was not able to join today. Thank you. Thank you, Dr. Philip Neri.
Thank you so much.